So hello and welcome to the lecture on sympathetic nervous system and adrenergic drugs. So you probably have had a lot of this information in your pharmacology 1 class. Most of this information should in general be review, but the big thing is that we tend to forget things here and there, and understanding how the medications work on the body is a big part of pharmacology, and understanding what the desired effects are, what we're going to see out of it, is going to be a big part of understanding not only what we're doing when we're giving a medicine, but what it means to the patient. So this overviews chapters 5 and 6 in your pharmacology book. They're pretty intensive chapters, so take it slow. But the big thing here is to give you a good overview. So maybe this video might help you just give a good overview and broad things to think about as we go through this information. So quick review of the nervous system. So here we have the central nervous system. It consists of the brain and the spinal cord. The brain and the spinal cord is the CNS. And then we have signals that are sent and received. So that signals that are sent and received means that we're going to have a response that's initiated. So when we're looking at this, this is where we get to the point we're called efferent and afferent signals. So efferent means that we're sending signals away from the brain. So you have a thought of moving your arm, so you're going to exit that signal. You're going to efferent that signal away from your brain, down your spinal cord, to the point where you eventually move your arm. So that would be an efferent signal. It starts at the brain and it exits, right? Efferent, E-F-F-E-R-E-N-T, right? It moves away from the brain and exits to where it does the effect on your body. So there's efferent signals, and then finally there's afferent, A-F-F-E-R-E-N-T, or afferent, right, to the brain. So this is where you have a signal from your fingers that a stove is hot. Then it sends a signal from your fingers to your brain, so it arrives to your brain. So it tells your brain, hey, that thing is hot, move your hand away. And then it sends an efferent signal back to your hand to move your hand away, right? So afferent means to the brain with an A. Afferent, to the brain, it arrives to the brain. Efferent, think away from the brain, it exits the brain. And I always like to remember that where the A, right, the letter A is pointing up towards the brain, and the letter E is exiting the brain, right? Capital letter A, right, going towards the brain. So when you're looking at this, you're seeing afferent signals. Here we go. Let's do blue. Afferent signals go towards the brain, and then efferent signals exit the brain, right? So that's one way of looking at it. Hopefully you got some of that memory brushed off from back in your anatomy and physiology day. So when we're looking at the peripheral nervous system, right, this is the link between the central nervous system and the body. So it consists of sensory and motor pathways. So sensory and motor pathways. That's a pretty big thing. And remember, this is the link between the central nervous system and the body. So there is no synapse. There is no synapse outside the spinal cord in the somatic nervous system, right? Soma means body, right? So there's no synapse outside the spinal cord, right? So when we're looking at this, the neurotransmitters in this release acetylcholine, ACH, right? That's acetylcholine. So you have your sensory ones. There's two sensory ones. So there's an involuntary here. We have the afferent signals that goes towards the central nervous system. Remember, afferent goes towards the brain. And then that signal stimulates, right? And it sends that sensory signal to the brain. Hey, that stove is hot. Tell the brain that that stove is hot. Then your brain gets that signal. And then you have motor. Motor signals are somatic, right? They help move the body. And some of these are voluntary, like walking or talking, right? Believe it or not, walking and talking are voluntary. So walking and talking, right? So those would be considered voluntary motor neurons, and these are controlled by efferent signals. Remember, efferent signals exit the brain, right? They're controlled by motor neurons that are sent from the brain. So when you're walking, you're sending a signal to your feet, to your legs, to your core, right? To all those areas that tell you to coordinate walking. Same thing with talking. You're sending those signals to your larynx to tell your vocal cords to ambulate and to move in different ways, right? Big thing here is acetylcholine directly stimulates skeletal muscle. Acetylcholine directly stimulates skeletal muscle. So if you're looking at this, if I touch a hot stove and I pull my hand away, right, that's my sensory telling my motor to pull the hand away. So that would be a good example there. But the ANS, right, the ANS does have synapses, but when we're looking at this, there are no synapses outside the spinal cord in the somatic nervous system. So when we're looking at this, why is it important to know about the motor pathway? Well, the motor pathway, you're like, why is he spending time on this? The motor pathway is so that we can manipulate or block different pathways. So looking at this picture here, right? Looking at this picture here, when we're looking at this whole thing, we're looking at trying to figure out how do we block these pathways? How do we manipulate these pathways with different medications? If we're going to paralyze a patient for intubation, we're blocking nerve stimulation there. So the gag reflex, in order to avoid vomiting during intubation, that's one of the things that we're looking at here. We're trying to manipulate or block that pathway to help that patient ultimately. So when we're looking at this, I want you to have the big picture of manipulation or blocking the pathway. So the sensory nerve sites, this is just a good summary picture of what we were talking about before. The sensory, right, sends signals towards the spinal cord, which then sends it towards the brain. The motor signals are efferent. The sensory are afferent, and they send the motor neurons away from the brain, and then it uses acetylcholine to then affect the skeletal muscle to move your hand away from that hot stove. And then as well in the system, you have the sympathetic and parasympathetic system. Now remember, in the parasympathetic system, preganglionic, you're going to have acetylcholine be both pre and post in the sympathetic and in the parasympathetic. But in the sympathetic, acetylcholine is preganglionic, right? We still see it preganglionic, but it releases norepinephrine post, right, in the sympathetic. So sympathetic is a little bit different than parasympathetic there. That, remember, parasympathetic is you relax and digest. It increases your gland activity, slows down your heart rate, your bronchi go to a smaller radius because you don't need it, your eyes will change, right? Same thing with sympathetic, you'll release that and then it'll give you that norepinephrine, that fight or flight system. And then your heart rate will increase, your eyes will change, your sweat glands, so on and so forth. So those are all things that we have to look at. So that adrenal medulla releasing the epinephrine is going to be a big thing here. So when you're looking at this pathway picture, I want you to think, hey, this is so we can manipulate or block some of these pathways. We're manipulating the sympathetic pathway when we give a sympathomimetic, right? A mimicking drug that will tell the sympathetic pathway to do something. Like when we nebulize a sympathomimetic like albuterol, we're mimicking that pathway, right? So same thing with racemic epinephrine. When we're nebulizing it, we're mimicking that vasoconstrictive pathway that's released with the sympathetic nervous system to help reduce edema in the glottis, right? That subglottic, supraglottic edema that's going on there. So we're manipulating those pathways. The autonomic pathways, the first one will start here. This is the ANS, right? This is what I was talking about 2 slides ago, the ANS, autonomic nervous system or autonomic pathway. This one is saying, hey, think automatic. Think automatic. There you go. So think automatic with this one. This one's involuntary. Involuntary is the key word here. This one, you don't have to think about it. It will control your blood vessels and your hollow organs. It controls your blood vessel and your hollow organs. So the big thing here is innervating glands, cardiac smooth muscle, right? It tells your heart to beat. Do you have to think right now, beat, beat? No, you don't, right? Your heart will just naturally squeeze and beat on its own. So it innervates the glands, the cardiac smooth muscle. And this one is controlled by, right? It's controlled by, so this looks like a key point here. The autonomic nervous system is involuntary and is controlled by the hypothalamus and the medulla oblongata. So here's your medulla oblongata, right? And then here is your hypothalamus here. Let me change to yellow. Let's see if that helps. Yeah, there's your hypothalamus. And there's your medulla oblongata, right? So you can see those, they're part of that brain spinal cord situation, right? So that's very important. There are two types of autonomic nerves. Of course, we've already talked about this. What two types are there? Well, there's the sympathetic and parasympathetic. There's only one system that will dominate on a daily basis. And this system sets our broncho and vasomotor tone. So when we're looking at this, hopefully you're not in a nervous place and you're in a parasympathetic place, and that's the system that's dominating on a daily basis. However, when you're taking an exam or something crazy is going on that's stressful, you might have a little sympathetic system that's sort of dominating on a daily basis there, and that can be very dangerous health-wise, right? So when we're looking at this, only one system usually will dominate on a daily basis. So we need to make sure to set that our broncho vasomotor tone is appropriate for whatever system that we're currently in, and hopefully that's a parasympathetic situation for you. So this is an involuntary system. Autonomic is automatic. It's involuntary. We're thinking cardiac, smooth muscle glands, and the hypothalamus and the medulla oblongata are your big ones here. And your two types of nerves are sympathetic and parasympathetic. And hopefully you have your parasympathetic dominating this on a daily basis. Right, so here is the autonomic pathway. One of the big things that we talk about, especially with the cardiac smooth muscle, and this is part of your hollow organ type situations, right? Hopefully your heart is a little anatomically hollow, not emotionally hollow, but that's a whole separate lecture. Autorhythmicity is the first one. Autorhythmicity here is going to be the first one that we'll talk about. We'll switch to purple. Autorhythmicity. There we go. Autorhythmicity is our first one here. And this one is obviously looking at smooth muscle. This means that the heart can initiate its own contractions. There's a cool video I show you in perinatology where it shows the heart autorhythmicity during fetal development. And so it has that cool animation in there. And this is where your heart decides on its own that it's going to contract and beat. Remember, this is part of your autonomic pathway, your automatic pathway. The autonomic nervous system, the ANS, controls contraction and relaxation of your smooth muscles and your heart. Smooth muscles and your heart, right? So this is going to be something that you have to remember, that you're looking at their own smooth muscles. They'll change. This pathway, the autonomic pathway, controls or changes according to the body's need. If I need my fight or flight response, if I have my sympathetic system that's going on, it's going to control that pathway to increase my heart rate, increase my blood flow to my brain, so increase my blood pressure, increase my circulation to get toxins out of my tissues so I can run faster, get rid of metabolic waste more efficiently. So this is what's going to be in control. So they'll have their own contraction, they'll have their own change according to the body's needs. So if your needs slow down, you're more in a relaxed digestive type state, that parasympathetic tone state, then your heart rate's going to slow down, your blood pressure is going to slow down, right? You're going to have more vasorelaxation, right? And when we're talking about antihypertensive drugs, we'll talk about drugs that are vasoactive for both antihypertension and vasopressors that are sympathetic reactive, right? They're trying to vasoconstrict, and what we're doing here is manipulating the autonomic pathway for those medicines. All right, so we just talked about the sympathetic nervous system. Let's go into a little bit more detail here. This one is going to be your fight or flight response. Fight or flight response, right? Fight or flight response, or you could put freeze in there. Some people will freeze. But fight or flight is going to be the big thing, and this is one system that has many, many synapses, including in the thoracic and lumbar region. Let's see, I'm going to put this in red because it seems like you might need to remember that it's mostly in the thoracic and lumbar region. There you go, I circled it in red. These ones have short, and it's already underlined, short preganglionic and long postganglionic chain. Short preganglionic and long postganglionic needs. And the big thing here is remembering that this is not essential for life. Not essential for life. You might think of it as a self-preservation thing and therefore essential to life. However, can you live life without being in a sympathetic state? Yes, you can. Life can continue without being in a sympathetic state. So this one's not essential for life. Now, if you're talking about survival in a stressful situation, that's a whole separate thing. But this one is not essential for life. One of the big benefits of this system, and I'll switch back over to purple here, is coping with stress, right? You're like, well, this sounds stressful, but the whole situation is to get you through stress. So it's going to release all these mediators that help you get through a stressful situation, like running from a threat or anything else. So it's designed to help you cope with stress overall, but it's not essential for life. The neurotransmitters in here, of course, you know these, of course, is epinephrine and norepinephrine. And these are your adrenergic responses, right? Your epinephrine and your norepinephrine. So the big thing is going to be understanding what reactions we have, and we'll get to that in this next slide here. So what reactions do we have? Well, we have a dilating of our pupils, right? This will inhibit you from producing saliva. So this would be a sympathetic reaction. This would be your fight or flight. Fight or flight system, right? Fight or flight system, your pupils will dilate. So that way you can obtain more input. You'll inhibit creating saliva because at this point, should you spend energy creating saliva versus energy running away from a threat or fighting a threat? No, right? So you're going to inhibit that. Your bronchi will relax, which means you're going to have bronchodilation, right? So you're going to go from a relaxed or a smaller lumen to a larger lumen, so that will allow for you to get air in and out of your system a lot faster. So you can exchange gas, not tire out as easily, right? So the bronchi will relax and dilate, they'll open up. The heart rate will increase, right? We're going to increase our heart rate, and that's to help our stroke volume. It's to help our cardiac output, right? Heart rate and stroke volume will both increase, and that really helps circulate the blood so we can get metabolic waste out of our tissues much faster, so we could run faster without getting tired and get away from that threat. So that's going to be our acceleration of our heartbeat and relaxation of our bronchi. And then the other thing here is going to inhibit GIs, right? Inhibit GI. So they're going to not really digest, right? Same thing with looking at this is digestion is not something you want to spend your energy on at this time. And so if you're not spending energy on it, you can focus that energy on something else like running from an active threat. So that's going to be something you'll see there as well. Their GI motility goes down. You won't have bowel sounds, things like that. The next part here is with the liver. It will stimulate glucose production and release. And you might see this on some of your trauma patients where their blood glucose is 400, right? Their blood sugar is pretty high there, and that's that stimulating that release. Or if we give someone steroids systemically, well, what can happen to their blood sugar as a response to steroids? It can go really high. And so we're going to see that production, and that's something we got to be cognizant of, especially in our diabetic patients that can't really bring down their blood sugars very efficiently, right? And then finally, the adrenal system right down here, secretion of adrenaline and noradrenaline. So that's going to be what can help us dilate and dump into our bloodstream and help us run from this threat or fight this threat, right? That's going to be the big thing that aids us in hopefully helping us get away from this danger. So a little bit about the neurotransmitters here. The chemicals released at the nerve ending, right, will then send it the impulse transmitted to initiate that response. And so here we're seeing it go from the chemicals released at the nerve ending, right? So it's being released here, and then it's being sent across that synaptic cleft to initiate the response at these receptor sites here, right? That receptor site there. So that synaptic cleft is the site where we try to send medications to block stimulation. So if we give you a paralytic, and we'll talk about neuromuscular blocking agents. So paralytics are also known as NMBAs, right? Neuromuscular blockading agents, right? So when we're looking at this, we're actually trying to block that synaptic cleft there to allow for there's no acetylcholine will go to that area of the muscle. So what happens to the muscle? Well, it no longer contracts and then it's paralyzed, right? So that's the whole point behind manipulating that pathway. So if we can do drugs that will block that pathway, that's one way to do that. So what drugs do we use that block these sites? So of course we're going to look at things like paralytics there, but there could be other things that we do as well. But one of the big things to understand here is knowing all your neurotransmitters and where they are. Because once we know what are the neurotransmitters and where they are, then the medications we use can help us understand where they're used to block them or to manipulate those pathways. So here are the neurotransmitters and where they're located. So your acetylcholine is located in your skeletal, your presynaptic nervous system, your postsynaptic and postsynaptic nervous. But when we're looking at norepinephrine, it's only in the postsynaptic place in the sympathetic nervous system. So ACH is both preganglionic and postganglionic and parasympathetic. We talked about this. Acetylcholine is preganglionic and the sympathetic. So if I ask you, hey, what neurotransmitter is preganglionic, and it doesn't matter what I say after that. One is preganglionic in sympathetic. One is preganglionic in parasympathetic. Then you're going to say it's acetylcholine. But the only time that changes is postsynaptic in the sympathetic nervous system, right? That's where you have your epi, norepi. But in your parasympathetic, it's all acetylcholine. It's all acetylcholine, pre and post synapse there. So with norepinephrine, it's only in your postsynaptic part of your sympathetic nervous system. So this was what controls your adrenal glands, your sweat glands, right? You get really nervous, you get in that sympathetic state, that anxious state. This is where you'll start to sweat, right? And this is that norepinephrine being released, causing these things. These adrenal glands are going to be releasing these things that will increase your heart rate, increase your blood pressure, cause you to sweat, all those things that make you nervous. So when we're in our sympathetic nervous system right here, right, we're on this final dot here, sympathetic nervous system, this is what releases epinephrine and norepinephrine into the bloodstream to send it throughout the whole body to have that reaction. Now, of course, preganglionic will still have acetylcholine, but postganglionic, this is where things change, right? Postganglionic, let me go to red here. Postganglionic, things will definitely change, right? Postganglionic is epinephrine and norepinephrine that's released, and that's to give you that fight or flight response. It's to dilate the pupils, it's to increase the heart rate, it's to increase the blood pressure, it's to dilate the bronchi, right? It's to help you be able to cope with that stress situation. Some basic terminology that we'll be looking at here is afferent, carrying impulses to the brain and spinal cord, efferent, carrying it from the brain and to the periphery, right? It exits the brain. This one, afferent sends it to the brain, efferent sends it away from the brain, it exits the brain. Adrenergic stimulates Adrenergic stimulates epinephrine and norepinephrine. So anytime you see an adrenergic, it's stimulating or mimicking epinephrine or norepinephrine. Anti, which is the key prefix there, anti-adrenergics blocks epinephrine and norepinephrine, right? So we're going to try to block that response to decrease blood pressure, to decrease all those sympathetic responses. So anti means to go against or to block, of course. Mimetic means we're going to mimic it, just like when we give an albuterol. It's a sympathomimetic. It mimics the sympathetic stimulation in the lungs, right? And it's a topical situation. But could it still have jitters and increased heart rate side effects in some situations? Of course. And of course, a lytic means to block or go against, like a parasympatholytic, like Atrovent or Spiriva. Those medications are designed to be parasympatholytics. They block parasympathetic stimulation. Therefore, the dominant system will be sympathetic nervous system. More terminology, of course, some of this should be recall from when you were in Pharmacology 1. Agonist means it's a drug that stimulates a receptor. So it's going to annoy that receptor. It's going to tell it, and this is that first one here, right? This is that first one here. Agonist goes to the receptor, and then they combine to have the drug effect, right? But if you have antagonist, it's a blocker. Antagonist blocks, and so it's going to go and it's going to merge with the receptor site, but it's just going to take up space. So that way an agonist or anything else is released can't park in that spot there. They can't have that effect. So we're going to release that there and take up that parking space, if you will, so that way there is no drug or action effect there. So terminology, agonist versus an antagonist. So let's talk about sympathetic receptor sites. One of the big things that we're going to be talking about here is the norepinephrine that's stored in the adrenergic fibers. And this is released via exocytosis. So exocytosis, you're like, that's a big word, I don't remember what it is. Well, exocytosis occurs when there's too much calcium in the cells and it pushes out norepinephrine. So it occurs, once again, it occurs when there's too much calcium in the cells and it pushes out norepinephrine. So when we're looking at this, it's going to be something that will is stored in the adrenergic fibers and it's released, right? It's released via that system, via exocytosis, right? So exocytosis, that's how it's released. We're going to have uptake 1, which means we're going to return to the adrenergic fibers. So this one is returning to the adrenergic fibers. And then uptake 2, which means we're going into the tissue site. So we're going to the tissue itself. Right? So uptake 1 is returned to the adrenergic fiber. So it's going to reabsorb it, and then the other one's actually going to go into the tissue, the place where it's supposed to go. Then we have enzymes, right? And the enzymes are a product or a part of metabolism and diffusion of these. So the two ones that we tend to look at here are COMT and MAOs. And you might have heard of MAOI inhibitors, right? So COMT and MAOs are going to be your two enzymes that we're looking at here, and they metabolize and they will allow for that medication to diffuse. So essentially, the adrenergic receptors and the adrenergic fibers will reuse or destroy with COMT and MAOs. It will reuse or destroy that neurotransmitter after it's released. So that's why the effect doesn't last forever and ever and ever and ever, right? They're going to either reuptake in uptake 1, right? It's just going to reabsorb, or it's going to absorb in the tissue, or we're going to have enzymes that just eat away and metabolize those things that are released. So that way it's not a permanent effect on the patient, right? That's why we have short-acting, long-acting, so on and so forth, right? The COMT and MAOs will help eat those up. right? They help eat those up. Right, and here you see the picture here of uptake 1 and uptake 2. So uptake 1 means that norepinephrine here is going back up into that adrenergic fiber. So that way it's going to be reused. So it's recycling. The norepinephrine is going back to where it came from, and then it can be used again later on. Well, uptake 2 down here means it got absorbed into that tissue site right there. And then finally the MAO and the COMT, not pictured here. It would be nice if they were, but they should be in there, would help metabolize any of these extra norepinephrines that's just hanging out in the synaptic cleft, right? So just pretend there's a bunch of those guys hanging out in that synaptic cleft. Then you're going to have some of that COMT and MAO start to consume those, like should have done a Pac-Man yellow there, but just gobble them up. So this is what you're seeing with the adrenergic receptor sites. And then up here, this calcium channel, right? This is that exocytosis where we have that calcium in the cells that pushes out that norepinephrine. So when that calcium builds up, when it comes in there, it's going to push the norepinephrine out and then cause that reaction, right? So hopefully you're feeling a little bit better about the adrenergic system. You might not be feeling too great, but there are two types that we're going to be looking at here. Adrenergic receptors, there's alpha receptors and beta receptors. So alpha and beta receptors, and here's your fancy alpha that we'll be talking about here. The alpha receptors lead to a sympathetic response, right? They lead to a sympathetic. So we're still talking your fight or flight. We're still talking sympathetic responses. And these are found in your peripheral blood vessels. So alpha responses are primary blood vessel stimulation, primarily blood vessel stimulation. And when it stimulates, it causes vasoconstriction. So when we do your racemic epinephrine, it's going to cause vasoconstriction. When we give epinephrine during a code, it's going to cause vasoconstriction to help pressurize that blood flow. So the primary effect is vasoconstriction, and it generally excites. That's its job, is to excite that sympathetic response, right? We will talk a lot more about alphas in our cardiac area of this course, especially when we're talking about antihypertensives and causing blood pressure to go up with vasopressors. But in the upper airway, we can provide decongestion like an adrenergic agonist like Afrin. Afrin is a vasoactive medication that we can use to help with decongestion for the upper airways, for the nasal pharynx there. But that's a whole good example there of an adrenergic receptors that you probably have used on your own upper airway or someone you know, right? And these receptors, these alpha receptors, are present throughout all the airways. Beta receptors are more prominent on airway smooth muscle, and that's why for drugs like albuterol or Xopenex, they're going to be more active than nebulizing just straight epinephrine to the beta responses, because you have mostly beta responses in your airway smooth muscle, right? And airways get smaller and smaller into the bronchi down to the alveoli, so you're going to have a lot less receptors the further down the airways you go as well. But especially as your tissue changes from PSCC, pseudostratified ciliated, columnar epithelium cells, to simple cuboidal, to finally simple squamous, right? Your effect of the medication goes down the further down the airways you go down. So when we're looking at this, alpha receptors are great. They're present throughout the airways, but you have more beta receptors in your lungs, in your lower airways, especially if you're looking for a smooth muscle reaction, then you need beta receptors. Smooth muscles need beta receptors, but if you're looking for vasoactive, then we're looking at alpha receptors. All right, more about beta receptors here. We talked about alpha in the last one, and I talked a little bit about beta here. Beta is found on the cardiac and smooth muscle membrane. So this is going to be looking at the cardiac and smooth muscle membrane itself and causing that sympathetic reaction. So beta 1's receptors are in the myocardium, and they will stimulate the myocardium. So what does that mean for the myocardium? It means that the heart's going to beat faster, stronger, right? It's going to improve the beat of the heart, the myocardium. It's going to improve that muscle contractility. Beta 2 receptors, right, when they're released, are receptors specific to smooth muscle. So this one's cardiac muscle with beta 1, and beta 2 is smooth muscle and causes relaxation. So when we give someone a drug like albuterol, it's a beta 2 specific drug, and therefore it relaxes smooth muscle, right? So alpha and beta 1, here is a good summary. You probably want to make sure you listen to this. Are you listening? Alpha and beta 1 excite. If we have alpha 2 and beta 2, they inhibit sympathetic response, right? Alpha 1 and beta 1 excite, alpha 2 and beta 2 inhibit that sympathetic response, right? Inhibits. All right, adrenergic. Well, when we're looking at the beta receptors, the trachea, the termini, the terminal bronchioles, they're all the way down to the conducting airways and to the transition zone, but they don't really go into the respiratory zone because the type of tissue down there is that simple squamous. It's not going to be able to receive that information and produce as much effect there. When we're looking at adrenergic effects, with your heart, let's talk about beta 1. With beta 1, you're going to have an increased rate in contractility and velocity, right? Contractility, let me put a comma there, and velocity. And this is going to increase your conduction, your AV node conduction. So it's going to increase your heart rate, contractility, and velocity. Now, when we're looking at beta 1 for your bronchi, right? When we're looking at bronchi, your smooth muscles will relax and dilate. You're going to increase secretions in your mucus glands, right? Increase. And then you're going to decrease your saliva production. So that would be your beta 1 adrenergic effect. Beta 1 adrenergic effect on both the heart and the bronchi. When we're looking at the mode of action, so the mode of action of adrenergic drugs, they stimulate the sympathetic nervous system to create the adrenergic effects, right? And then we can look at the sympathomimetic, right? We're mimicking those drug effects of the sympathetic nervous system. Drugs that block the sympathetic nervous system are anti-adrenergic or sympatholytic. Remember, lytic is that suffix that means to block, right? So all of these, when we're looking at the mode of action of adrenergic drugs like albuterol or epinephrine, these stimulate the sympathetic nervous system to give the adrenergic effects, or the drugs that we give will mimic the adrenergic effects as well. In the lungs, we have alpha, beta 1, and beta 2. And we've already talked a little bit about this, but here we go. Alpha, present in the lungs in small numbers, and it's stimulated by norepinephrine. So that's what we're looking at here, is that norepinephrine that stimulates it. And alpha will actually cause bronchospasm, right? Alpha in the lungs will actually cause bronchospasm. But when we look at beta 1 was in the alveolar walls that respond to epinephrine. So this is that vasoactive, because remember, when we get to the alveoli, that's where there's a lot of perfusion down there. So that'll react to epinephrine. It's not very significant though, because it's not going to cause a lot of effect down there with that simple squamous. But where would it be significant? There we go. We're looking at the heart, right? So it's going to be more specific on cardiac performance, cardiovascular performance. Now, that's why we're not really beta 1 fans for nebulization as well. But when we get to beta 2, we're going to mediate relaxation of bronchial smooth muscle. And that's the primary effect that we're going for with beta 2, is that relaxation or dilation, if you will, of bronchial smooth muscle. And it goes all the way in the lamina propria from the trachea to the terminal bronchioles. That lamina propria is that middle layer of that tracheobronchial tree. And the tracheobronchial tree is all the way till you hit the terminal bronchioles, which is your last part of the transition zone, right, before you get to the respiratory. So we're looking at beta 2, pretty much the whole tracheal bronchial tree. The whole tracheal bronchial tree will respond to beta 2. In the lungs, you're going to have blood vessels, of course. Blood vessels, a lot of perfusion in the lungs, especially to make mucus, to do all the work of metabolizing, to move airways, to supply cilia with what they need, right? There's a lot of stuff going on in the lung tissue, especially the conducting airways as well. So there's a lot of blood vessels there. So in the lungs, the norepinephrine will cause vasoconstriction in the lungs. Vasoconstriction in the lungs, which is a natural response to norepinephrine. It's supposed to cause vasoconstriction in the lungs. But with epinephrine and beta-2, it will actually cause vasodilation. So if we give someone epinephrine in their lungs, right, and the epinephrine will cause that beta-2 release, that beta-2 will actually allow for vasodilation, will allow for better perfusion with beta-2. Better perfusion with beta-2 compared to vasoconstriction with alpha, right? So if your body releases epinephrine naturally from the adrenal medulla, right? If it releases it from the adrenal system, then you're going to have more bronchodilation and vasodilation effect from that epinephrine release compared to a norepinephrine. Norepinephrine would cause pulmonary vasoconstriction because it's an alpha. Epinephrine would eventually release beta-2 in your lungs, which would cause vasodilation. The mucus glands in your lungs, when we have alpha and beta receptors, the stimulation usually increases mucus production. And this is good, especially if you're trying to help with airway clearance therapy. This can help the secretions be a little bit less sticky, if you will, when we're looking at this. So let's talk about adrenergic bronchodilators. So these are just some synonyms, right? Adrenergic bronchodilators are also known as sympathomimetic because they mimic, right? They mimic that. So when we're looking at the mimetic part of it, that suffix, right? We're looking at anything that mimics or it works on the adrenergic system. All these, all catecholamines that are released are derivatives of catecholamines, right? So all our catecholamines or derivatives of catecholamines. That's this first bullet point here. All our catecholamines or our derivatives of catecholamines. And catecholamines you naturally have in your body, right? These are naturally occurring. These are water soluble. They're continually in circulation in our bloodstream, so you naturally have this circling around. Whether or not it's being sent anywhere important is a whole separate thing. But the three that we're looking at here are dopamine, epi, and norepi. So dopamine, epi, and norepi. Norepi is your three catecholamines that we're looking at here. So this is something your body naturally releases to stimulate a sympathetic response. So let's look at some catecholamines. So the catecholamines will mimic epinephrine. Right? They mimic epinephrine. So these are a group of similar compounds. They all have pretty similar compounds or makeup. The big things that they mimic is going to be your tachycardia, increasing blood pressure, right, to help perfuse your organs so you can run faster, jump higher, get away from that threat. They'll cause smooth muscle relaxation so you can breathe deeper and faster, right? Higher minute ventilation so you can get away with that. They may also cause skeletal muscle tremors, right? Remember, that's the #1 side effect of your bronchodilator is actually that tremor. And then, of course, they're going to cause CNS stimulation, right? So that smooth muscle relaxation is that beta-2, right? Beta-2 in the airways, right? Beta-2 in the airways, which will allow that smooth muscle relaxation. It does have similar effects when the sympathetic is stimulated as well. But catecholamines are that naturally occurring thing in your body. So what are some indications, right? This is a good thing to know, a good slide. Relaxation of smooth muscle in the presence of a reversible. Notice I'm circling the word reversible there. In the presence of a reversible obstruction. So your indications for giving a sympathomimetic would be reversible obstruction, right? Smooth muscle reversible obstruction. So where do we see this, right? We see it with asthma. We see it with bronchitis. Now I know bronchitis, itis is inflammation, right? Yay, med term, but bronchitis is inflammation. Well, that inflammation can cause bronchospasm, and hopefully that bronchospasm is reversible, which is where that would come into play. Other things, emphysema. Emphysema is natural destruction of the airways walls, and they become very floppy. So that bronchodilator can help with improving the radius of their airways. Same thing with bronchiectasis. And then any type of obstructive airways disease issue that we're looking at here, including cystic fibrosis, right, so on and so forth. Bronchiectasis, you name it. So when we're looking at this, the big indication is going to be the presence of reversible obstruction. So they're going to produce bronchodilation by stimulating beta-2 receptors on smooth muscle in the airway. Beta-2 receptors on the smooth muscle, right, on the airway smooth muscle. And that's going to help reverse their airway issue. So that's why pre and post PFTs, where you do a pre and post forced vital capacity or flow volume loop, it should help us understand if the condition's reversible, and if so, how much, right? Indications for short-acting. So we're going to start with short-acting agents, right? SABAs, short-acting beta-adrenergics. If there's an acute, notice that the key word here is acute, an acute reversible airflow obstruction, acute reversible airflow obstruction. And the duration here is about 4 to 6 hours. 4 to 6 hours, right? 4 to 6 hours. And that's why after a bronchodilator, you have to wait 4 to 6 hours before you can do a pre and post PFT again, right? So you have to let that medication sort of get out of their system. So short-acting agents include your albuterol, your Xopenex, your levalbuterol, and metoprolol, right? And these dosage and brand names are in the drug table that's in your book, but do make sure that you go over those and understand which agents are short-acting, right? Which agents are short-acting agents that I might ask you, which of the following are short-acting agents, right? You need to know which ones are short-acting versus long-acting or ultra-short-acting, right? So you're going to have ultra-short-acting, short-acting, and long-acting, right? So the next one that we'll talk about will be long-acting agents. So long-acting agents, these are used for maintenance, right? It's already controlled. Maintenance control of bronchospasm, nocturnal asthma symptoms, nocturnal symptoms that are there. These ones last a lot longer. They last for up to 24 hours, right? 12 to 24 hours. So these are usually either Q-day or BID, right, twice a day. And some of these long-acting agents are going to be your salmeterol, Ceravent, formoterol, aformoterol, indacterol, olodactyrol. So when we're looking at those are for your primarily COPD populations, and then you're going to see some asthma as well. Right, you're going to see that. So these are primarily for your chronic conditions, not your acute bronchitis episodes, but these are more for your chronic conditions. And then obviously you need to know your dosages and brand names for these as well. And the big thing with these long-acting medications is education is vital. The big thing with education is making sure they know when to take these, that these are not rescue medicines, right? This is not something where they should go take their Ceravent 8 puffs. No, right? Right, do not do that, right? So if they do, that could be very, very dangerous. So these are just for maintenance and long-term control. They're not for when they're feeling short of breath. And then now we're going to go to ultra short acting. So ultra short acting, right? So you do need to know what's in your ultra short acting, and your long acting medication categories. And then why would you use those categories? Well, remember the long-acting indication would be maintenance and control of things like COPD and asthma. We're trying to reverse acute airflow obstruction with short-acting. Well, with ultra-short-acting, the big thing here is to do things like control airway bleeding, right? That's why we need ultra-short-acting, or to reduce airway swelling, right? So that's where ultra-short-acting comes in place. So if you're looking at the purpose, ultra-short-acting is to control airway bleeding or airway swelling. It can also be, when we're looking at short acting, it's to reverse acute airflow obstruction, and then from long acting, it's to help with maintenance. So the definition of ultra short acting means less than 3 hours. right? You get less than 3 hours on this medicine before it sort of exits their system, before it's metabolized, right? So when we're looking at this, we're looking at drugs to reduce post-extubation stridor or epiglottitis, croup, bronchiolitis, and that would include your racemic epinephrine, right? Racemic epinephrine, remember, can be aerosolized, it can be nebulized, or it can be instilled down the endotracheal tube. When you're looking at this, there was an acronym called NAVAL, which was Narcan, atropine, Ventolin, and then E was epinephrine, and then V was vasopressin, and then L was lidocaine, right? So those were things that you could directly distill down the airways, right? And these are all, that was part of that short acting, right? Because you could do epinephrine down there, and the whole point, or atropine would help as well with reducing vagal stimulation and things like that. So when we're looking at these, the reducing the airway swelling, that would be your racemic epinephrine nebulizer, or anything with that epinephrine, because we're trying to vasoconstrict to help reduce that swelling or airway bleeding when we're giving epinephrine down a bronchoscopy, right? So ultra short acting, know your indications, know what types of drugs are in that category. When you're looking at short acting, right, post acute airflow obstruction, usually 4 to 6 hours, albuterol would be in that category. And then your long acting drugs, 12 to 24 hours for maintenance and control of things like COPD, asthma, and Cerebint or salmeterol would be one of those, right? So you should know your 3 primary categories here and what's included in those. All right, why are we looking at catecholamine structure? Because it is awesome. Catecholamine structure, it'll look at the nucleus and then your side chain over here, and the length of that side chain can tell us a lot and how long it lasts in their system. So when we're going to look at this, the catecholamine structure, usually it has a benzene ring, which you see there, 2 hydroxyl groups. There you go. Hydroxyl groups, and then it has an amine side chain, which I went ahead and labeled here, and then the benzene ring, put a ring on it, right? That's this guy here, right? The benzene ring, and that's that basic structure. So they all have very similar structures when we're looking at these chains. So let's get into this a little bit. So beta adrenergic agonist. So agonist means it stimulates. It doesn't take up the parking space and block it, but it stimulates it. They bind to beta-2 receptors. So they bind to beta-2 receptors. They'll increase cyclic AMP, and then that will cause then the relaxation of smooth muscles, right? So that cyclic AMP increasing will lead to relaxation of bronchial smooth muscles. So in other words, bronchodilation. And then these are specific. Beta-2 agents are specific to bronchodilation. And that's one of the best things about these is their side effects are usually going to be fairly minimal, right? So things like what we're looking at here is they're less likely to increase things like heart attack. So less likely, or not heart attack, heart rate. So they're less likely to increase heart rate because they're specific to the beta-2 sites. They don't have much alpha in there. There's not much that will go into that systemic absorption. But if we nebulize racemic epinephrine to the lower airways, it's not beta-2 selective, and it can cause an increase in heart rate, right? Because it's not beta-2 specific. So that's why, yes, in a pinch, could you nebulize racemic epinephrine to have some effect? Yeah, you could, but it's probably going to have more side effects than if you did a beta-2 specific medication, right? That's why that chain tells you exactly what it's going to work on. So stereoisomer, it sounds like the name of a band, right? The stereoisomers. There are 2 different arrangements that we're looking at of these, 2 different ranges. So they're usually mirror image of the other side chains. So we have right-handed and left-handed, right? So the R isomer is the right-handed one, the S isomer would be your left-handed one, and they have very similar chemical properties. But the R isomer, another one, is also known as like a levo isomer, and it's a good twin, right? It's the good twin, right? The R isomer is the good twin. It's the good twin because it causes bronchodilation. equals bronchodilation, right? So that's the good twin that we like to talk about, right? It isolates, it causes bronchodilation. It's going to be a good one. Now you're going to have the S isomer, and this is the left one, right? And so this is the mirror, right? This is also known as a dextroisomer, and this would be your bad twin. Bad twin. And so this one will isolate, but it does nothing. It isolates it, but it does nothing or has no rebound effect. So it's not going to have as much effect. But their chemical properties are fairly similar when we're looking at these, but the R isomer is going to be our advantage here, and that's why something like levalbuterol, which is the next screen, levalbuterol is this one here, and it has the R isomers only, which is kind of cool, which means it's more beta-2 specific, which in theory means less side effects, right? And that's the advantage there. Now, the disadvantage is it's like 6 times the cost of albuterol. But when we're looking at albuterol, it should say albuterol. It's both the R and S isomers involved there, but the levalbuterol is the R isomers only. It's isolated, so that's why it's even more beta-2 specific, so even less cardiovascular side effects. However, when we're looking at epinephrine, it's an R isomer. Racemic epinephrine is both R and S isomers. So if you're wondering what's the difference between epinephrine and racemic epinephrine, right? You've always wondered that. Here's your slide. Epinephrine is just the R isomer, right? And that's why it has just the bronchodilation effect, whereas racemic epinephrine would be the R and S isomer, which has more effect on the cardiovascular structure. So let's talk about keyhole theory. The keyhole theory says the larger the catecholamine side chain, the more specific it will be. So the longer we make it, the better, right? So the longer that side chain, the more specific it will be to that site. So when we're looking at Xopenex versus albuterol, it has a much longer side chain, right? And that's why it's more beta-2 specific. And here is this example. Here's an S isomer that's left-handed, and here's a right isomer that is right-handed. And so we're seeing here that the longer that side chain is, the longer these side chains are over here, the more specific they will be to their site, because there's less effect that it's going to bounce off somewhere it's not supposed to go, right? You have a key that has very short keys, those little keys that open up those tiny little locks, compared to the key that opens up your house, right? There's a difference. One's very short, a small key, right? That's designed to open up just tiny little locks, very simple locks, compared to a very long key that you use for your house, right? That's designed to open up a more complex system. So that's where you're going to see that difference between the keyhole theory. The longer the key is, the more specific it is, the more detailed it is, the less side effects you might see from it. So let's talk about epinephrine. Good thing to talk about. This is a potent catecholamine, and it can cause bronchodilation as well. It stimulates both alpha and beta receptors, so you're going to have more side effects from epinephrine. In fact, they used to nebulize epinephrine forever ago, before albuterol was a thing, right? Good old history lesson there. It does have a high prevalence of side effects like tachycardia, increased blood pressure, tremors, headaches, insomnia, you know, those things that you'd get from taking too much caffeine, right? The epinephrine type stuff, right? And it is available in synthetic racemic mixture, right? As a synthetic racemic mixture as well. But this one has both the R and the S isomers in the racemic mixture. So the racemic mixture has both R and S isomers, right? Compared to just regular epinephrine. So when we're looking at this, epinephrine can be nebulized and injected, but racemic nebulizer is only nebulized, right? Neb only. So remember, we're looking at vasoactive with racemic mixture. With epinephrine, we see both cardiovascular and beta-2 effects with it. Now we're going to look at the metabolism of catecholamines. When we're looking at the metabolism of catecholamines, They are inactivated by COMT, and we've already talked about COMT being some of those things that gobble up at the synaptic cleft, right? They're those little things that will help eat up everything that's sort of left over after that activation of the sympathetic nervous system, right? And the COMT is found in the liver and the kidneys. And we have something called the first pass effect, which is what we'll talk about here in a bit. But these are unsuitable for oral administration because they are inactivated by the gut and the liver, right? They're inactivated by the gut and the liver. So that's why they can't be taken orally, right? That's why we can't do a pill for these. So they are also inactivated by other things like heat, light, and air. And those things will definitely make those inactive. And this is why it comes in a form of like a brown bottle or a foil pack. So that way those things will really avoid the heat, light, and air parts. And like I said, this is something your body naturally creates. And then the duration of these are probably about 1.5 to 3 hours. So 1.5 to 3 hours is your duration for these because the COMT will eat up these medications in there. Resorcinols are not inactivated by COMT. So the COMT will not eat those up, right? They're not hungry for those. So it's not inactivated by COMT. And these are great for maintenance therapy, right? Resorcinol agents. They have a longer duration. They last 4 to 6 hours. Longer duration, so they last a lot longer. So 4 to 6 hours. They have a much slower peak effect, so it takes a lot longer, usually about 30 to 60 minutes. And some examples of this would be the tributaline, metoprolol. So tributaline is something that we actually even used in NICU medicine as a tocolytic to stop the smooth muscle of the uterus from contracting to help stop preterm labor. And then we can also use tributaline as a medication, IV medication for bronchodilation effect. But remember, COMT will not destroy this. So you're going to have more cardiac stimulation, and it is a modified catecholamine. So a lot more cardiac side effect, and especially because COMT is not going to be able to digest it. It's going to have a longer effect in their system. Selenogens, these are also a modified catecholamine. They are available as MDIs, nebulizers, syrups, extended release tablets. So it sounds a lot like albuterol here, and that's what I'm talking about. Albuterol would be a selenogen agent. The benefits here is their beta-2 preference, right? They are specific to those beta-2 sites. They can be effective PO by mouth, or they will peak in about 30 to 60 minutes, and they'll last for about 4 to 6 hours. And they're specific. Like I said here with these selenogens, the beta-2 specific ones, they're going to have a lot less cardiovascular side effects. Lev-albuterol, right? This is that other one. This one is the pure R isomer. Remember, albuterol also has the stereoisomers as well, but this one is just the pure R isomer, right? Just the pure R isomer, known as Xopenex, and it comes in a MDI or small volume neb. The nebulizer doses, there's 4 of them that are out there, and you might see many of these different ones out there. I know we've used the 0.31 in the neonate world quite a bit, 1.25 and 0.63 I've seen in the adult side quite a bit as well. Big thing with the side effects of levoalbuterol, they're a lot less, right? So the side effects of a tremor and heart rate changes are less significant. So for cardiac sensitive patients, might be a better medication there. They do have a higher peak effect than albuterol at the 1.25 milligram dose. So that's where that comes into play at that higher dose. The big side effects are similar with a similar dose to racemic albuterol. That would be your 2.5 milligram dose. So you might see the same side effects if we're giving lots of it, which would then, why are we spending 6 times the cost if we're going to do a lot of it, right? So that's why you might see some facilities might not carry something like levoalbuterol unless it's prescribed brand only. So let's talk about long-acting agents. Long-acting agents offer a lot less frequent dosing and even overnight protection. Remember, overnight, 6 to 8 hours. And a lot of these will last 6 to 12 hours, or even 12 to 24, sorry, 12 to 24 hours. So that's the advantage here. They're great for overnight protection. They are extended release albuterol that's out there. Vasospire, which you'll see later on, is out there, but there's salmeterol or Ceravent, formoterol, aformoterol, indacterol, olodacterol, right? And those things will mimic the effects of the sympathetic system, but they are slower release. They take a lot longer to take effect, but overall they're going to help maintain for a longer time period. Great for maintenance and COPD, which we talked about, COPD and asthma being your two primary reasons for doing these, right? A lot more reason for doing these. So extended release tablets, albuterol tablets, are more used in your pediatric population. So Vasospire is the thing that I was talking about here. Extended release is ER, right? And it can be used more for kids, like I said, 4 to 8 milligrams oral tablets. Activity time is around 8 to 12 hours, so it takes a while before it goes out of their system, but it's a great medication if especially they're uncompliant with other forms. Salmeterol is the dry powder inhaler. You might have seen this out there. It does have bronchodilator effect. It's a slower onset than albuterol by about 20 minutes. Time to peak is around 3 to 5 hours in that range. The duration's 12 hours or longer. It depends on how quickly their system gets rid of it. But this one is beta-2 selective. It has a slower peak time of effectiveness, but it like I said, this is not for rescue. This is not like I'm short of breath, let me take my Ceravent Discus. No, that's not this case, right? This one is longer duration. We need to take it. Formoterol, this one is beta-2 selective as well. 3 minutes to bronchodilation effect, so it's pretty quick, and it can last to a half a day. It's a 12-hour medicine, and you can do this in a small volume neb as well. Besides doing a dry powder inhaler, used for asthma, exercise-induced bronchospasm, or COPD. It's FDA approved for maintenance of asthma and exercise-induced bronchospasm in children as well. So this is one of those cool things that you might see out there that might help these kids long term. Formoterol, or Brovana, right, is a single isomer of formoterol. It lasts up to 12 hours. It's a nebulized solution, and it's a great maintenance of COPD drug or maintenance of asthma that's not controlled by an inhaled corticosteroid. And we'll talk about more of that maintenance of inhaled corticosteroids as well later on, but it's a great drug for that situation, for maintenance. Notice the key word here, maintenance. Bilateral, this one is also beta-2 selective. It is approved in different combination formulations. So Briolipta, Enerolipta, right? Those two. This one's considered ultra long acting. It's great for COPD and asthma, COPD treatments, and just combined with fluticasone is what you're usually combining it with. So like an inhaled corticosteroid of some sort. So these are great ones to help do that long-lasting maintenance control. Some safety concerns that we see is not to use these things with patients who are already controlled with an inhaled corticosteroid. Once asthma is controlled, the long-acting beta agonist should be discontinued is traditionally what they would do. So once we have them under control, it takes about 4 weeks or so to let an inhaled corticosteroid kick in, right? 4 to 6 weeks before it becomes effective for inhaled corticosteroids. So once it's controlled with the steroid, then we can take the long-acting beta agonist out of their formulary. So it should be used only if patients are not controlled with an inhaled corticosteroid. Not controlled with an inhaled corticosteroid. So it's a short-term use only, so we're usually looking around 4 to 6 weeks at most until that inhaled corticosteroid builds up. But children, they usually have to use it in conjunction with corticosteroid or those little guys, right? But once their asthma is controlled, they need to DC that LABA, right? So what's the mechanism of action? When we're looking at alpha receptor stimulation, we're looking at vasoconstriction, especially the upper airway. So that's the primary reason of giving alpha receptor medications is the upper airway. Beta 1 receptors is usually to increase heart rate and contractile force. So it's usually looking at blood pressure medications or vasoactive medicine and cardiovascular activation here. And finally, beta 2 receptor stimulation is to relaxate the bronchial smooth muscles. And so that's going to help because one of the things too with beta 2 receptor stimulation is they help inhibit inflammatory mediator release. So even though it's not a steroid, it should help stop that cascade of inflammatory mediators. And then the other thing too is they help stimulate the cilia, right? And that's the one thing that you might have seen out there is for people that are post-op general surgery, even if there's no respiratory history, that they'll be giving them medication like a bronchodilator. And the reason why they're doing that is for mucociliary clearance to help avoid things being stuck in their airways and causing a potential for pneumonia there. So that's why you might see a doctor post-hip surgery on a patient that has no respiratory history whatsoever order bronchodilator nebulizers. Well, why would they do that? Well, the whole point there would be to avoid, to stimulate the mucociliary clearance, especially after general anesthesia or a long surgery or a painful situation where people aren't going to be coughing and breathing deep, to activate the mucociliary escalator to avoid a postoperative pulmonary infection. So if you ever wonder why they order nebulizers on people that have no respiratory histories or maybe they just have a pneumonia or whatever, the whole point is that mucociliary clearance, right? So that's the airway clearance therapy is going to be the primary indication. So even if someone broke a rib and they're on room air, they might order bronchodilator medicines. Well, the whole point of that is for mucociliary clearance to help avoid developing a prophylaxis, if you will, for pneumonia. All right, alpha receptor activation. When we're looking at these agonists, things that will agonize or cause the effect would be phenylephrine and epinephrine, these two. They will result in vasoconstriction of the peripheral blood vessels, vasoconstriction of the blood vessels in your fingers and toes, right? This will also include blood vessels in the airway as well as like the trachea, right? So this will also include the airway, not just the fingers and toes. We're going to talk a lot more about this in the cardiac drugs when we talk about pressors to increase blood pressure, but these alpha agonists is to help increase back pressure, hopefully to the brain, the heart, the kidneys, the liver, to those vital organs, and away from your toes and fingers that may not need that blood flow quite when that patient's blood pressure is so low. So let's talk routes of administration. Inhalation is going to be pretty straightforward. There is the meter dose inhalers, dry powder inhalers, nebulized, and then respimats. The advantage of nebulized, and that's why you might see it a lot in the hospital currently, nebulized doesn't require as much coordination. Now, should you still coach the patient on the SMI technique? Absolutely. But with a nebulizer, but the patient, if they're already having trouble breathing, might not be able to take a deep breath, right? So that SMI technique might not be something that's doable, but they'll still get more medication with it being nebulized versus trying to coordinate and take that slow deep breath in with pause, right? So that's why you probably will see more nebulized medications than either DPI, MDI, or even respimats in the acute care setting. Catecholamines, we've already talked about this. Catecholamines are ineffective orally, right? Because they're metabolized by the liver, right? But the big benefits of these catecholamines, so you're looking at systemic administration of these, are going to be the very rapid onset, so very quick to act. We can use much smaller doses. There's a lot less side effects, and they are delivered directly to that target organ, so it's very, very selective. And then they're relatively safe and painless overall, which is kind of a bonus there. So what are some limitations? Well, limitations of medication delivery include time, especially with nebulized medicines. We're looking at around 10 to 15 minutes or so, depending especially with some of those home nebulizers. Public embarrassment, especially with kids. Kids don't want to be seen doing their nebulizer in their car, at their house, by their family, right? There's that whole embarrassment component. And then a lot of times it can be difficult to use it correctly. Imagine someone with arthritis trying to activate and open up the little pill for their Spiriva, or to have the right technique for the MDI, and it hurts their hands just to squeeze the inhaler, right? So there's a lot of factors that we got to consider when we're looking at the different routes of administration. Is the time a factor? MDIs are much faster than nebulizers. Public embarrassment, MDIs are usually more socially acceptable than something like a nebulizer. And then difficult to use correctly, MDIs might be more difficult to use than something like a small volume nebulizer, but then cleaning a small volume nebulizer is usually more difficult than making sure the MDIs are clean, right? So there's a lot of factors that go into this. So let's talk continuous nebulization of albuterol. So you might see this out there. Sometimes we like to add Atrovent to this as well. It depends on the situation. So your mileage may vary out there. But continuous nebulization of albuterol, the indication is going to be an asthma or COPD exacerbation. Understand there is different protocols out there. Some people will do 3 back-to-back small volume nebulizers instead of a continuous nebulization as well. So you might see that out there. That's been studied as well. But if they do talk about continuous nebulization, especially on your boards, usually it's about 10 to 15 milligrams an hour for an adult. The delivery method, usually you'll have to refill a small volume neb, right? 3 back-to-back nebulizer doses, right? 3 doses, 2.5 milligrams to 5 milligrams, right? Back to back to back. Or you might use a large volume nebulizer. There's multiple out there. Even vibrating mesh nebulizers, like the Aerogens, are a possibility where they would use a syringe pump to continuously fill that nebulizer part. But the big thing here is the toxicity and monitoring. There's a lot of potential complications here with cardiac arrhythmias, and more on adults than kids, but cardiac arrhythmias especially, it can take out potassium, cause hypokalemia, right? And that's what we see there. Hyperglycemia, and then even tremors. So there are a lot of side effects that can be associated with this. The NAEPP, right, the National Asthma Educator Prevention Program, also recommends doing the 3 doses versus doing a continuous nebulizer. So you might see that difference out there. They also will recommend on your boards, there's usually a question about doing a continuous nebulizer for people that are hyperkalemic, right? They have too much potassium, like renal patients, and so they want you to give at least 10 milligrams an hour for that. So you might see that out there for that as well. The oral route, remember, catecholamines are ineffective by mouth, so albuterol is a modified catecholamine, so that's why you can have it in tablets, right? So the advantage here is it's easy to use, it's a short administration time, great for kids. It is reproducible, and the dosages are very well controlled, like the Vasospire extended release. These oral tablets are great for nocturnal asthma patients. The big disadvantage is they have a longer onset of action, so they're not really good for those acute situations. They're more systemic side effects, right? More the tremor, more that type of side effects to it. And there is a loss due to the first pass through the liver, right? So there's a loss of effect that can go on with those as well. Let's talk about parental route, right? So this one, it means it's IV, intramuscular, subcutaneous. It's any route other than by mouth, right? And so this is used usually in emergency management. I'm going to underline emergency management of acute asthma, So this is usually a last resort that will require an infusion pump, a cardiac monitor, close attention to systemic side effects. And this is what I was talking about with terbutaline, right? That medication that we can use as a bronchodilator. Terbutaline, like we said, we use it as a tocolytic to stop preterm labor, but we can also use it as a bronchodilator as well. Lots of side effects with that. Lots of side effects with it. So sub-Q epinephrine would be one that would be used for things like anaphylaxis. Sub-Q terbutaline will slow and help dilate, will slow down things like smooth muscle contraction. So that way, that's why it helps with stopping preterm labor, stopping uterine contractions, as well as the smooth muscle in your lungs, which should help dilate them as well. Adverse effects. The definition of adverse effect or side effect is any effect other than the intended therapeutic effect. So these include things like tremors, and tremors are typically dose related, but means you've gotten so much in your system. The more dose, the more side effect, right? Cardiac would be one of your first ones that you would see. Tolerance, where your body builds up tolerance to it. The CNS effects would be there as well. Fall in their oxygen levels, right, because of the metabolic disturbances that are caused. And then they can even have sensitivity to additives as well. So there's a lot of side effects or adverse effects. If there is a 20% change in their heart rate, right, with their albuterol treatment, you stop it. Right, that's an adverse effect. You're supposed to stop the treatment and reassess the patient. If the drug effectiveness, you can have over a long-term use of it, a loss of beta receptor or downregulation of inflammation. So inhaled corticosteroids can reverse desensitization to the beta receptors and potentiate the response as well. So sympathomimetics are very good at increasing glucose, so watch out for that as well. Watch their blood glucose and that effect as well. But you're going to see that increased glucose is usually caused by an increase in perfusion. When we're looking at that, we're going to change our perfusion, especially when we're looking at that fall and that PaO2. You can see that intermittently. It'll cause an increase in perfusion to areas that are poorly ventilated. So we're opening up the lungs so we have more ventilation to those areas. And usually that will last only for mostly about 30 minutes, and after that it should return back to normal. So any of these side effects that you see, you're supposed to stop. If they're significant, stop and reevaluate the patient. All right, so how do we assess these patients, right? So assessment, we're going to monitor things like their peak flow rates, how well they do on their treatments afterwards as there changes, physical assessments, pre and post treatments, which will include their heart rate for a 20% increase. Sounds like that's important since I just mentioned it a little bit ago. Even subjective reactions, like how they felt afterwards. ABG, the big thing here is also looking at their patient education. A lot of times we'll do these for a pulmonary function test in our outpatient PFT labs. Breath sounds, right? There's a change in their breath sounds, especially after they get these medications. What about long-acting beta agonists, right? We just talked about, okay, looking at assessing these patients after SABAs, but what about LABAs? Ongoing PFTs, ongoing pulmonary function tests, is going to be your big one to see over time, do they have better flow rates? Are they using the agents as much? Do they have less nocturnal symptoms? Are there less exacerbations than they used to have before? Are they missing less days of school than they were before? Are they able to reduce their inhaled dose of corticosteroids, right? So there is something called an asthma paradox, which means there's an increased evidence of asthma mortality and morbidity despite advanced treatments. But the big thing here is understanding, well, why is that? And that's a good question for us to discuss in class.